Hi, everybody. Today we're going to cover Chapter 7, but only the first part. Chapter 7 is tremendously detailed, and after I really got into it, I realized it was not going to be effective to try to do it in 1 week. So we're going to do it in 2 weeks. I'm moving some other things around a little bit. We actually really, after this, have only 2 chapters that we're going to go into great detail. The pediatric stuff I'm going to handle in a different way at the end of the course. We'll talk about that. But anyway, we're going to cover slides 1 through 28. So I have all the slides for Chapter 7 done, but this week slides 1 through 28. And let me go ahead and share the screen. So you will see the topic, which of course I bet you already know. I'm going to try not making it bigger for a while because when I do that, it's very sensitive to the movement. So I think that this will work effectively, and I can still use my pointer, and the slides don't tend to pop around and I end up missing something. So we're going to be covering the cranial nerves, including deglutition. And that is Chapter 7. This slide simply shows the 12 cranial nerves, which I know you have seen in other courses. You've seen it in this course. Certainly you do want to know them. You want to be able to use the number and the name interchangeably. They both bring into consciousness the same thing. There's a summary of the functions, and in a few cases, like the olfactory nerve, we're not going to go into much more detail than what you see right here on this summary. And in some of them, the ones that have to do with speech and swallowing, we're going to go into a great deal more detail than what you see here. All right. Now, this is a reminder about the cortical nuclear tract, since we're going to be talking about motor and sensory in this unit. We're all about the cranial nerves, but I want to remind you about the cortical nuclear tract. This is not new information, it's old information, but just a reminder that the upper motor neuron input from the motor cortex to a certain of the cranial nerves that have motor functions are by way of the cortical nuclear tract, which is a companion to the cortical spinal. It's exactly the same thing, really. Cortical spinal neurons go down to the spinal cord, cortical nuclear just go to the brainstem, but they're carrying the same kind of information. And the nuclei that receive input from the cortical nuclear tract are the three nuclei. The first 3 go to extraocular muscles, or impact extraocular muscles, the oculomotor nucleus, the trochlear nucleus, and the abducens nucleus. Number 5, the trigeminal, one of its nuclei gets motor input from the cortical nuclear tract, and that's the motor trigeminal nucleus. The facial nucleus does for muscles of facial expression. Nucleus ambiguus does for control of the throat and the larynx, and the hypoglossal nucleus for control of the tongue. So those are the nuclei. How many are there? 7, I guess, that receive input from the cortical bulbar or cortical nuclear tract. It's 2 names for the same thing: cortical bulbar or cortical nuclear. This is an illustration that you've seen before, and it shows the pattern of decussation of the cortical bulbar or cortical nuclear tracts. And this is a reminder, at least I think it's a reminder, and maybe a little bit of it's new, that the input to those nuclei that we just looked at is different depending upon which nucleus. Most of them do receive input about equally from the 2 sides of the brain, meaning that they receive ipsilateral input about 50%, and contralateral input about 50%. And those are the oculomotor nucleus, the trochlear nucleus, and the abducens nucleus. Let me put them in a category. They move your eyes. Let me jump ahead to clinical implications. When you have a unilateral stroke that results in a contralateral weakness, eye movement is fine. You don't see anything because 50-50 input prevents them from having a weakness on one side. Then the motor trigeminal nucleus, which subserves, as we'll get into this, chewing muscles, you don't see anything from the stroke that causes the hemiparesis because They get 50% input from each of the two sides, and they have the protection of that. The upper portion of the facial nucleus for the forehead and the upper part, that's 50-50 input. So you don't see drooping of the eye. You don't see weakness of inability to elevate the eyebrow on a side where there's a hemiparesis. So there's protection there. And then the nucleus ambiguus, which provides input to the pharyngeal muscles, the velar muscles, and the intrinsic laryngeal muscles. Those have protection, 50-50 input. Okay, now, the nuclei that receive mostly contralateral cortical bulbar input would be the hypoglossal nucleus for the tongue, and the portion of the facial nucleus that innervates the lower 2/3 of the face. So that's what you're going to see. You're going to see a lot of patients who have a big stroke on one side of the brain, and they'll have a language problem if it's on the left. They'll have a minor hemisphere syndrome if it's on the right. That's about language and cognition. And then they're going to have, let's say it's on the left, they're going to have a right hemiparesis. You ask them to stick their tongue out, they're going to demonstrate a right tongue weakness. It will deviate to that side. And they'll have droopiness in the lower 2/3 on the right side of the face. Upper part's okay. So basically that's in a nutshell. Now we'll look at this in different ways, but I like this slide because it just reminds you that all of this is prevented from having problems with a unilateral stroke. And this is not. This is going to have a problem. Okay. All right. Now, going through the cranial nerves one by one. Let's do 1, 2, 3, 4, and 6 here, just introductory. Number 1 is the olfactory. It's a special sensory nerve, and we're not going to go into detail on it. We don't really test it. The optic nerve, number 2, we actually have gone into considerable detail in the last chapter, and you know quite a bit about it. So you know about visual fields and so forth, and we're not going to add anything in this chapter. You already know it. The nerves for extraocular movement, for eye movement, are 3, 4, and 6, and we will look at a little bit of detail at those. Here we go. Well, just back to 1 and 2 for a moment. I guess I haven't completely finished with it. Olfactory is tested by neurologists or ENTs, not SLPs, as far as I know. I don't test it. Number 2, we do test that as SLPs, but generally we don't. An ophthalmologist or a neurologist can test the four quadrants of the visual field: upper right, lower right, upper left, lower left. They can do it for each of the 2 eyes. SLPs generally just test for the right and left visual fields. And oftentimes we don't do it separately for the 2 eyes unless we know that there's a problem with one eye. We just test the 2 fields with both eyes open. And functionally speaking, that gives you all the information you need to know. You need to know if the patient is operating with full visual fields and can therefore potentially read and find objects on a table as you give them commands or whatever it might be. This is a reminder of old information. Lesions that are distal to the optic chiasm, distal meaning away from the brain, and that would be the optic nerve we're talking about, they lead to blindness, partial or total, depending how bad the damage is. If you cut an optic nerve, that eye is blind. Lesions that are proximal to the optic chiasm produce contralateral homonymous hemianopia. You lose the opposite visual field, and that would be typically for SLPs, the place in that pathway that gets interrupted is the internal capsule. That's because that's vulnerable to big strokes in the territory of the MCA, which also affects the language zone on the left, or the area for minor hemispheric syndrome on the right. All right. Number 3, the oculomotor nerve. Now we're going to look at these three in a little bit of detail. The nuclei, and there are 2, the nuclei for the oculomotor nerve are located both in the midbrain. The oculomotor nucleus is a somatic efferent nucleus, and it innervates 4 of the 6 extraocular muscles that move your eyes. You look to the right, look to the left, up, down, that's extraocular muscles. The nerve also carries visceral efferent neurons, and the nucleus for those visceral efferent neurons, that is where their cell bodies are located, is the Ettinger-Westphal nucleus. It's right next to the oculomotor nucleus in the midbrain. And what that does is two things. It controls the pupil size, the dilation and contraction of the pupil in response to light, and it also controls the upper eyelid. So if you have a palsy of this nerve, you will see a drooping of the eyelid because the muscle inside the eyelid is weak. The name of the muscle is the superior tarsal muscle. It is a smooth muscle, not a striated muscle. And you'll note that I have put it in red. I'm not holding you responsible for that information. It's a little bit far afield for us. I just want you to, know some general information about these and be able to identify a problem with one of these nerves, but it's really not part of our diagnostic process. You will see patients who have problems in these areas. The clinical signs and symptoms for damage to this nerve would be impaired pupillary constriction, a partial, what's called a ptosis, meaning a drooping of the upper eyelid. That is pronounced ptosis without the P. They also do have a lateral strabismus, meaning the eye is in the relaxed posture, it's deviating to the right. If you tell them to look to the right, you don't see anything wrong. But if they're looking ahead, the one eye is off to the right, and that would be a lateral strabismus. Along with any strabismus goes what's called a diplopia, double vision. Makes sense. If your eyes are not aligned, you're going to see two different things, and you're going to have double vision. All right. Here is an illustration of that. The eye is drooping, and somebody is pulling the eyelid up a little bit. And you can see that same eye is off to the side. That's the lateral strabismus. They would also have a diplopia. And you can also see that they have a dilated pupil. So those are the three characteristics of what's called an oculomotor palsy or a third cranial nerve palsy. All right, the fourth cranial nerve, trochlear, has its nucleus in the midbrain also. It's relatively close to the pons. It innervates the superior oblique muscle. Note that that is in red. You're not responsible for it. And the clinical signs and symptoms are a slight upward strabismus and a diplopia. I should put slight upward strabismus in red too, because honestly, I'm not going to ask you that one. Then the abducens, that nucleus is located in the pons, somewhat close to the medulla. The nerve actually exits the brainstem right by the medulla, still in the pons, but right by the line between the two. And it innervates just one muscle, lateral rectus. It's somatic efferent muscle, or nerve, I should say. And the sign is very clear. It's a medial strabismus. That muscle pulls the eye out to the side. And if you lose it, it's going to deviate to the midline, toward the midline. It's called a medial strabismus. That's the actual deviation. And the diplopia is the double vision that goes along with any strabismus. I actually like that one a lot because it very simply illustrates what these three nerves do and the extraocular muscles do in a very simple way, because only one muscle involved. Okay, let's look at the location of those three nuclei. And this is a familiar illustration. It should be, I think. Let's see if I can get an arrow. Not really. Here. That's the problem with doing this. Let's go to the big screen here. And I'll try very hard not to make my slides advance without being willful about it. Here is the oculomotor nucleus, right here. Here's the Ettinger-Westphal right next to it, so that's for number 3. Here's the trochlear, it is in the pons. Here is the abducens, right there, it's in the pons too, and you'll note, just for a footnote here, that the nerve actually exits the brainstem right by the border between the pons and the medulla. All right. Okay, now we're moving on. We've left 1, 2, 3, 4, and 6 behind. That's 5 of them, and we have 7 left. These are, except for the red one, far more relevant to speech language pathology diagnoses. We assess them in greater detail, and they have greater impact for us. They would be the number 5, the trigeminal, the facial, 7, 8, the vestibulocochlear, 9, the glossopharyngeal, 10, the vagus. Let me skip to 12, the hypoglossal, very important. The reason I put the spinal accessory in red is that it controls 2 muscles. They are the sternocleidomastoid, which turns your head, and also, if you work in concert, the 2 of them together, flexes the neck. And the trapezius muscle in the back. Not too relevant for speech, really. Most SLPs probably don't test them. I don't. The reality is also that you would only have a lesion with them if you had, you'd only have a problem with the sternomastoid, the trapezius function, if you had a peripheral nerve lesion. And that's, as far as patients we're going to see, going to be really rare. Not sure I've ever seen one, actually. So that's why I put that in red, and I'm not going to ask you anything about that, except maybe the name. Okay, so moving on. Let's look in detail at the trigeminal nerve, starting with the sensory part, and then we'll move to the motor in a minute. And this is kind of familiar information. It's not the first time you've seen it. I don't remember the chapter now, but you've looked at this before. You've looked at the 3 sensory nuclei of the trigeminal nerve, the mesencephalic, main or chief sensory nucleus, and the spinal trigeminal. You know their location: the midbrain for the mesencephalic, the pons for the main sensory, and the medulla for the spinal nucleus. Part of the lower part of the pons and the medulla, I should say, be a little more precise there. And you know how they function. Mesencephalic subserves proprioception and kinesthesia. Pretty important for speech, actually, when you think about it. The mains is for fine touch, and fine touch, not proprioception, fine touch, light tactile stimulation. And this is really the one that we test. So we'll get into the testing of this one. And it subserves a relatively large and important area, essentially the whole face divided into 3, and the entire top of the mouth, oral cavity, and the entire bottom of the oral cavity, all the way back to the oropharyngeal port. What's the oropharyngeal port? It's the back of the mouth defined by the posterior border of the velum and the fascial arches. And then you come down to the bottom of the fascial arches, and if you connected to the 2 of them with an imaginary line, that would be at the horizon of the tongue. You can see the anterior 2/3, then it drops off. Posterior 1/3 is behind that. That's what I'm talking about, that line. That's the border, that's the oropharyngeal port. And so 5 subserves everything back to that, but not behind it. That's going to be 9, and we'll get there. All right, and then the spinal trigeminal subserves pain and temperature information. SLPs might sometimes test for temperature sensation, but I don't think very often, but they certainly could. And but I don't think we test for pain, at least I don't. All right. Now let's look at those nuclei that we just went through. Here, let me just point out the 5th cranial nerve, and here's its 3 branches, which you know about: ophthalmic, maxillary, mandibular. Here's the main thing: it's a big nerve. And it comes into the side of the pons. That's what they're trying to illustrate here with these dotted lines and that. And then the neurons that are going to be carrying proprioceptive and kinesthetic information, they turn and go toward the midbrain and synapse here in the mesencephalic nucleus. Those that are carrying light touch, synapse here, not in the dark part, that's going to be the motor part, but in the light part, the chief sensory or principal sensory nucleus. And then here's the spinal nucleus of the trigeminal, or just called spinal trigeminal nucleus. They're kind of different terms, but once you know what it is, they all sort of make sense. They all have trigeminal in there someplace. And they all have spinal or main or chief or mesencephalic. So this just reiterates the functions of those three, and this shows where they are. And like I said, I think you've seen that before. Okay, now the motor. Let's look at the motor. The motor nucleus is called the trigeminal motor nucleus. It's also called the masticator nucleus, and that's because it subserves mastication, which is chewing. But I think the label here used here is a trigeminal motor nucleus, and that's fine. It's located in the pons, and it innervates 8 muscles, and they all grew from the branchial arches. That's why it's a branchial efferent nucleus, and it's a branchial efferent nerve. The 8 muscles divide into 3 categories. The third category is SLPs we're not too concerned with. Let me just get those out of the way. Jumping down to 2 tensors, that's how I remember it. There are 2 tensors, tensor veli palatini and the tensor tympani. The tensor tympani is in the middle ear. Audiologists can actually test it for responsiveness, and so an audiologist can test it. SLPs cannot. And SLPs potentially could test the tensor veli palatini. It participates in VP closure, but I don't know how they would do it because it's one muscle and with a whole bunch of other muscles that act in concert with it. So it's really not possible to tease that one muscle out and test it differentially. Then that leaves 6. 3 mandibular elevators that would close the mouth, and 3 mandibular depressors that would open the mouth. Well, I'm a little bit sloppy in saying just open the mouth because of course you're using facial muscles too, but to depress the jaw or to elevate the jaw. Let's look at the elevators first. The temporalis is on the side of the brain, the side of the head, and the masseter muscle is on the outside where I'm putting my fingers here. And the medial pterygoid is exactly parallel to the masseter, but on the deep surface of the mandible. It's almost like a sling of muscular tissue that pulls the mandible up or elevates the mandible during mouth closure. Do review your 344 textbook to take a look at those muscles if you're a little bit vague on them. Particularly probably on the medial pterygoid and the lateral pterygoid. It's good to review those because they're a little bit more difficult to visualize because they're deeper. Then the 3 depressors are the lateral pterygoid, the anterior belly of the digastric, and the mylohyoid. Let me start with the last 2 because they're simple. They're under here and they pull the jaw down. So take a look again at 344, the muscles that pull the jaw down. The mylohyoid basically forms the floor of the mouth. It attaches to the hyoid. And if you keep the hyoid stable and contract the mylohyoid, pulls the mandible down. Anterior belly of the digastric is superficial to that and essentially does a very, very similar action. The lateral pterygoid attaches to the part of the mandible that fits into the joint. And it's almost like a finger, sticking up there and going into the joint. And that the lateral pterygoid attaches to it and pulls it forward, and it will rotate the whole jaw down. That's how it accomplishes its movement. It also protrudes the jaw. So if you keep the elevator muscles contracted so that you don't open the jaw, and you contract the 2 lateral pterygoids, the jaw will just jut out. I'm trying to show it now. Maybe I need to do a profile for you to be able to see it, but you know what I mean. It just juts out, and we'll get into that when we test it. Now, remember the innervation of all of the muscles that we're talking about here is by way of the mandibular division of the trigeminal nerve. In other words, the other 2 divisions, the ophthalmic and the maxillary, they don't have any branchial efferent neurons in them at all. All right, now let's look at the nucleus that we're talking about at this point, and that is the trigeminal motor nucleus. And here it is in the pons. It's right next to the chief sensory nucleus. And they're trying to illustrate here that the axons project out through the mandibular division. And they go to those 8 muscles. All right. Here is just another illustration of what we just looked at. And here you see this long interconnected sensory nucleus with its mesencephalic portion, main sensory portion, and spinal portion. And here you see the motor nucleus of the trigeminal nerve. And we're looking down at a brainstem here. And I think they're trying to show the very large trigeminal nerve coming out here, but they've cut it pretty close so we don't see the 3 branches. Okay. We're going to look at the sensory zones of the 3 branches now, and these subserve light tactile stimulation, which is the area that an SLP would touch and would test, I should say. A lot of SLPs limit their assessment to 8 zones. The maxillary, 2 on each side, so that's 2, 1, 2. The mandibular on the outside, so they'll do light tactile stimulation testing for here, 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 that's 4. And then they'll go into the oral cavity and test the roof of the mouth and the floor of the mouth on the surface of the tongue, the anterior 2/3 of the tongue, in other words. So surface of the face and the territories of those 2 branches, and the palate and the anterior 2/3 of the tongue on each side. So there's our 8 zones that an SLP would test. Okay. There we go. Let me make sure that I didn't miss a slide. I did miss a slide. That's what annoys me about this, my mouse. This shows the zones on the outside, on the face. And you can see the ophthalmic division. I've been referring a lot to the forehead, but it does come all the way back up to the center of the head. So it's a bigger zone. But we would, if we tested it at all, we'd test out here. Here's the maxillary division shown on the face again, and you can see it includes the upper lip. Keep in mind, it's not just the skin though. It's a whole wedge of tissue. It's everything deep to it. So that's why the roof of the mouth, the upper teeth, the upper alveolar ridge, everything back to the velum. And part of the velum. Part of the velum is subserved by 9 a little bit, but essentially the roof of the mouth. And then the mandibular division here. You can see it's the lower lip, it's the side here, and it's the floor of the mouth. Back to the oropharyngeal port. Okay, how do we test the muscular function? Oh, let me go back and I just reiterate, I kind of did it in passing a little bit too much. How would you test it? You'd have them close their eyes and you take a Q-tip and lightly touch and ask them just to signal you when they feel it. It's very simple, and you do the same thing in the mouth. You can also ask them if they felt it on the right or the left, but either which way, you keep the eyes closed. If you have a person with language or cognitive difficulties, it is more difficult to test. There are various ways you can do it. For example, with an aphasic who really can't understand the instructions, you could get them to close their eyes, and generally they'll open their eyes when they feel something. If they don't open their eyes. And you try to determine if they tend to give you that response more often with stimulation on one side or the other. But it is a little more tricky. Okay, now how do we do the muscular function testing? We are going to assess the general strength of mandibular elevation. You will just have the patient clench the teeth while you palpate, just put your fingers lightly on the location of the masseter muscle and the temporalis muscle, masseter down here, temporalis up here, and you're just feeling basically for movement. You can also, for mandibular elevation, put a little pressure downward on the chin. I'm doing it with my finger right here on the chin. I'm pushing down and I'm asking them to clench their teeth so I can feel the strength of the elevation. For mandibular depression, we do just the opposite. We push up on the chin and ask the patient to open the mouth, and we feel the strength of the depression movement. For testing asymmetry or the symmetry of the strength or the asymmetry of the strength, we're going to have to do jaw protrusion because you're not going to be sensitive enough to feel it with these tests that we just went through. But if they have a weakness on one side, they will deviate the jaw to that weak side. Remember, the lateral pterygoid is pulling the jaw forward. Now, kind of the way I think of it, it sort of helps me, I hope it might help you, is you think about going like this, but if one side isn't doing it, it's going to go like, I just knocked my glasses, it's going to go like this. So you're going to deviate to the weak side, and that's how you see an asymmetry. Keep in mind that you're only going to see an asymmetry if they have a peripheral nerve lesion. In other words, actual damage to the fifth cranial nerve or the mandibular division of the fifth cranial nerve itself. If the lesion is in the cortical bulbar pathway, you won't see any weakness because of the 50-50 input from the two sides of the brain to that trigeminal motor nucleus. So there's protection to it. You could have a lesion in the brainstem itself that knocks out a trigeminal motor nucleus, and then it would be the same thing in terms of the muscular function that we've just talked about on this slide. You would have all the signs of a unilateral lesion of the fifth cranial nerve. But in addition, you would have other things going on because that same lesion would have interrupted other ascending and descending pathways doing other things in other places. And so it depends upon the cleanness of the lesion in a sense. So I hope that makes sense. And of course, we'll talk about that more, but yeah, it's pretty easy to tell. Okay, let's go to the seventh cranial nerve. The seventh cranial nerve has multiple components, actually. It has a branchial motor component or a branchial efferent component, and this is for the muscles of facial expression. You know, the ones, I always hated them because they're sort of hard to learn, but they elevate your eyebrows and close your eyes, smile, and all that stuff. It's muscles of facial expression, plus two other muscles, the stapedius in the middle ear and the posterior digastric. Again, the audiologist can test that stapedius, and we really can't test the posterior digastric differentially, but certainly we do test the muscles of facial expression, and we'll go into that. There is a visceral efferent component as well, and that is for salivation. You have several salivatory glands, and the superior salivatory nucleus innervates the lacrimal gland. It produces tearing, and but I'm not going to include any of that on visceral efferent functions are, as far as this part is concerned, are too far afield from what we're interested in. There is also a visceral afferent component, and this is important for us, pretty important, and that is for the nucleus solitarius, and it provides taste sensation for the anterior 2/3 of the tongue and also a little bit of the palate. Not going to worry about the palate because we don't test it, but for the anterior 2/3 of the tongue. So that's visceral afferent neurons carry taste information back to the brainstem, specifically the nucleus solitarius, for taste from the anterior 2/3 of the tongue, and that is visceral afferent. And then there is general sensory functions too. Note they're kind of obscure, and so I put the whole thing in red. I'm not going to ask you anything about that. It subserves pain and temperature sensation in the external auditory meatus and the tympanic membrane. Well, we're not going to test that. I can guarantee you that. So let's put it in red. Okay, now let us review, and this is a review, although I think the illustration is different, but the information is the same. I want to just review the pattern of cortical nuclear input to the facial nucleus. Remember, you can sort of divide the facial nucleus into two. That part, which is going to send neurons out to the upper part of the face, and that part that's going to send neurons to the lower 2/3 of the face. The part that subserves the upper face receives bilateral upper motor neuron input or cortical bulbar or cortical nuclear input, 50% from one side and 50% from the other. So spend a little time with this slide and study that. You've seen it before and probably don't have to spend too much more time on it. And then the lower 2/3 of the face receive input from neurons that receive mostly, about 80%, contralateral cortical bulbar input. So this is a reminder of what you've already known, but I know that that was a challenge to learn it, and it's good to look at it again as we tick through these cranial nerves. All right. This is an illustration of the pathway to the muscles of facial expression. And I put this part in red. It's actually, I do believe it's in your book, but there's what I would refer to as a tortuous pathway through the petrous portion of the temporal bone for this nerve.
Oh, that's fine.
And it's not detailed. It's not detailed on the. It's not detailed on. I'm not going to put it in the quiz. Basically, I don't care about that pathway. But the nerve then, once it's taken its tortuous pathway through the petrous portion of the temporal bone to get out of the skull, it emerges through the stylomastoid foramen. And then this is kind of important. You can see here it's coming out the stylomastoid foramen, and it passes through the parotid gland, which is a big gland here. It's under the skin. You can, if you get a inflammation of it, you can actually feel it. It'll puff up. As it does in the mumps, I believe. And it passes, and then it breaks apart into goes all over the face. As you can see, all these branches going to all muscles of facial expression. But the significance of it is sometimes people do have to have a parotid nerve, parotid gland, which produces saliva. They have to have it removed for various medical reasons, and that can be a challenging surgery to make sure that there is not damage to the facial nerve. All right. Okay. Now, let's cover taste. Remember, taste is going to be subserved by the facial nerve for the anterior 2/3 of the tongue. So the taste receptors are distributed over the anterior 2/3 of the tongue. And the first order neurons will travel back toward the brain. They have to get to the brainstem, of course, ultimately to the nucleus solitarius. But they're going to travel back with branches of the lingual nerve to the trunk of the lingual nerve here. Now here's the trunk of the lingual nerve. So these are branches. They're just traveling with the lingual nerve. And the lingual nerve, by the way, is carrying also other kinds of information, general sensation. So if you just touch the tongue, what is carrying the information from the surface of the tongue? The lingual nerve, or branches of the lingual nerve. So you want to try to imagine, the way I would describe it would be two trees whose trunks are growing very close together. So much so that the branches are all intermingled like this, and they're distributed all over the surface of the tongue. Some of those are from one tree carrying pain and temperature information. Some are from the other tree carrying fine touch and proprioceptive information. And for us, light touch, that's the one we're mainly concerned with. And they're all going to go back through the lingual nerve. But at a certain point, the neurons that are carrying pain and temperature deviate from the lingual nerve and go through this thing called the chorda tympani. Chorda tympani. It's actually going to run through the middle ear. It's kind of past it, but not exactly through it, but very close to it. It gets the name tympani from the tympanic membrane. So it's running very close there, and it comes back. The lingual nerve comes back through the chorda tympani and goes through the petrous portion of the temporal bone, and then it finally enters through this nerve called the nervus intermedius. Now let's find the nervus intermedius. It's here. I just found it a little while ago. Chorda tympani. Oh, here it is. Nervus intermedius and nucleus solitarius. So this is not, I put it in red, a lot of it in red, because it's not really, it's nothing we're going to differentially test or figure out on our patients, but it's in the book, and I just want you to, I want you to be aware of this, but not to be responsible for anything that's in red. So this part I think is kind of easy to understand. You can just think about two trees with their branches all intermingled, and at one point they're in a trunk called the lingual nerve, and then the ones carrying taste deviate off from with the chorda tympani and go to form the nervus intermedius. Here we can just track them all the way up, see, and into the nucleus solitarius. So what's important? Anterior 2/3 of the tongue, 7th cranial nerve, nucleus solitarius. Okay. And where is the cranial? So far, I don't think I've linked in for you the 7th cranial nerve. I've got the chorda tympani, and here finally is the 7th cranial nerve with the nerve going out to muscles of facial expression. So it travels with the 7th cranial nerve for a little short distance here. But a lot of times it's separate from it. Okay. Hope that's not too confusing. What's the takeaway? Anterior 2/3 of the tongue, 7th cranial nerve, nucleus solitarius, tortuous pathway. All right. Now, how do we test this? Now, we're going to test mostly for muscles of facial expression, and the task is simply to do two things: smile, and you can look at the symmetry of it, and raise your eyebrows. Here is a person smiling and raising eyebrows, and you can see that it looks normal. So this individual they have no palsy. They have no 7th cranial nerve palsy at all. What is called a peripheral facial palsy would be total weakness on one side of the face, upper and lower. What's called a central facial palsy, which you will see a lot, would be weakness of the lower 2/3. And that central facial palsy will always be from a lesion that's on the opposite side. Why do they call it central? Because the damage is in the central nervous system. Why do they call this one peripheral? Because the damage is in the peripheral nervous system. All right. Now, how about this one? This person has again, the task is to smile, and you can see he's smiling on the left side, and you can see he's not smiling on the right side, his right side. And there is a droop of the eyelid, of the eye, not the eyelid, but the eye is drooping on this side. And you can see the eyebrow is elevating here on the strong side, not elevating on the weak side. So that's what you're looking for. Elevation, no elevation. That is a peripheral facial palsy on the right. How about this one? The command is to smile and to raise your eyebrows. And he is certainly smiling on this side, not on this side. And you think, well, there's not much elevation there, but compared to the last image, see, this person is elevating a little bit, but there's no wrinkling here. So that is another illustration of a less severe peripheral facial palsy. What I'm looking at is the degree of elevation here. This line, nothing. This looks like he's had Botox over here. Why does he look like he's had Botox? Because he has weakness of these muscles and poor retraction on the right. So that is, again, a peripheral facial palsy, not as severe as this one. Okay. Now we get to questions, but I'll leave those for you to answer, and we'll go over them in class. And then next week we'll take off with the other slides.